Good morning, good afternoon, good evening, wherever across the globe you may be listening in from today. Welcome to the National Academy of Sciences and Engineering and Medicine's webinar on the fourth wave in the future, a webinar to discuss crisis standards of care. I'm Dan Hanfling. I'm a vice president on the technical staff at IncuTel. IncuTel is the strategic investment arm of the US National Security Establishment. I'm also co-chair of the National Academy's Forum on Medical and Public Health Preparedness for Disasters and Emergencies. And some of you may know me as being co-chair of the three committees that help to develop the systems framework for catastrophic emergency preparedness and response, what we call crisis standards of care. Today's session is the first in a series of discussions that we felt was important given the current climate and status of healthcare service delivery across the country, to help inform the work of an upcoming workshop series that is going to focus on evolving crisis standards of care and ongoing lessons from COVID-19. But we felt that it was critically important, given what's happening in the country today, to hold this pre-conference webinar, if you will, to discuss urgent matters at hand, and hopefully at the end of this 2-hour session, provide you with some materials that you can use to help further your planning and capabilities where you're delivering healthcare services. So as we get underway, again, I will remind you that we will be holding a series of webinars, the first one to be held on Monday, September 27th, and then every 2 weeks thereafter. So set your calendars now for the 27th, October 11th, October 25th, November 8th, and November 22nd, as we take a much deeper dive on this set of issues that we call crisis standards of care. So I want to thank you all for joining us, and I'd really like to thank our distinguished speakers and panelists for their efforts in putting this together so promptly. This came about in a somewhat of an ad hoc fashion over the last couple of weeks, and we're glad to be able to present this information to you today. As we all know, COVID-19 has fundamentally changed the delivery of healthcare services, forcing us to make difficult choices and laying bare many pre-existing health, medical, and public health frailties. As a fourth wave of COVID, driven by this Delta variant, surges across the nation, extreme shortages of key resources, especially those related to nursing, respiratory therapy, and other practitioners who are needed at the bedside, have put the US healthcare system on the verge of collapse. Like Italy and India experienced at earlier points in this global pandemic, the surge in demand for care can exceed available resources, forcing the most difficult choices upon practitioners. And as we're experiencing now, and as we have come to realize, pandemics do not end quickly. So our solutions must continue to evolve, and that is the point of our gathering here today. We have one very important tool in our possession, vaccines. But as we've seen in the United States, fully 1/4 of the population, perhaps more, have been hesitant in accepting its protection. And as a result, hospitals in many regions of the country are overwhelmed. The state of Idaho has formally invoked crisis standards of care. The largest hospital in Alaska, Alaska Medical Center, is operating under crisis standards of care, with patients waiting in their cars for hours to be seen in the emergency department. I understand that as of yesterday, the Helena, Montana-based St. Peter's Health System has enacted crisis standards of care as their critical care units have become full, and hospitals in Billings and Bozeman seem like they're following close behind. Meanwhile, intensive care units and hospitals in our southern states, Florida, Texas, Mississippi, Alabama, have few or no bed vacancies. So what are we to do? During this webinar, our speakers will explore suggested solutions to real-time issues and ways to ensure fair decisions are made, even when systems are breaking under the strain. The speakers and panelists will discuss a recent publication that my good colleague and writing partner, John Hick and Matt Wynea and Eric Toner have penned under the National Academy of Sciences Perspectives, which you can find. I think we're going to put that link in the chat if you have not seen it yet. And that is going to set the table for our discussion over the next hour. So let me tell you quickly how we're planning on running this 2-hour session. We'll open with Dr. Matt Wynea, one of my co-authors, who will provide an overview of that NAM perspective. He'll also give you all some background on crisis standards of care, how we have thought about the framework and what that means. And then we will bring on a series of respected colleagues who will speak to a selection of some of the current critical issues related to crisis standards, and will offer up some of the solutions that they have found to be helpful. We'll try to run through that in the first hour, leaving the second hour, the second half of the webinar, open to invite your commentary, your questions, recognizing the challenge of Zoom and doing this virtually. We'll try to get to as many of those questions and comments as we can. But if you leave that material, we can also try to follow up with you after the meeting. And again, as a reminder, this is just the pre-conference, if you will, to what will be a series of workshops that are soon forthcoming. And so we hope that you will come back and join us for the rest of this dialogue. Look, we're all in it together. And so we have to find solutions that work. And I think the intent here is to try to find those best practices where we can push them forward and try to implement them so that at the end of the day, we're trying the best that we possibly can to take care of our patients and try to save as many lives as we can. For the purposes of the meeting, we'll use the Q&A box for questions. Anybody who wants to send remarks in the chat, I suppose we'll look at them, but we're going to really try to use that Q&A box for questions. And please, again, feel free to submit them as we go through. We would ask that you identify yourself, so your name, your title, your position, your affiliation. That would be helpful to us to provide context in our answers. And with that, I'd like to invite Dr. Matt Wynea to kick us off and provide some opening remarks. Dr. Wynea is Professor of Medicine and Director of the Center for Bioethics and Humanities at the University of Colorado, a member of the National Academies Forum that I chair, and a co-author on this most recent piece on crisis standards. So Matt, over to you. And again, thank you to all for joining us this afternoon. So Matt, we see your slide and now just waiting for your audio. Which we still do not hear. Matt?
Apparently, I cannot simultaneously unmute myself and show my slides. So I'm going to have to stop sharing and go back. Sorry, can you guys hear me now?
Yeah, so I can hear you. I would just wonder if you want to, if you send your slides forward, if one of the National Academy staff might have them, then perhaps they can present while you're speaking.
I would be happy to do that. Let me just send my slides. Aurelia, I'm going to share these with you.
So apologies, but like all great planning, there are always hijinks, and this should be the worst of our problems this afternoon. So thank you for bearing with us. But I know Matt has put together some excellent slides, and I think it would be worth sharing them with the audience if we can do that. But in the interim,
let me just go ahead and share again. Now that my
no, we don't see your slides though. So why don't you
should be coming up now.
There you go.
Is it working now?
Yep, we got you. Audio and video. All right, you're on.
Okay. So sorry about that. The few comments I wanted to make just in preface to the conversation today are to point out, number one, that these issues that we're talking about have a pedigree. There has been a good deal of conversation. And for many of us, we sort of trace the initial conversations about this back to 2009 and the creation of the Institute of Medicine's framework in the letter report. But of course, anyone who's been in the field since before 2009 recognizes that the issue of triage and the alteration in the standards of care and the types of care that you can deliver under circumstances of extreme scarcity has been with medicine for generations. So these are not brand new issues that no one has thought of before. The core issue here, and I'm going to assume some level of background in disaster response and the concepts of crisis standards of care, but I'll just say the core concept here is that in circumstances where there's an extreme shortage of some resource, whether it's staff, whether it's space, whether it's resources like medications or ventilators, it is possible to have such an extreme shortage that you cannot provide the quality of care that is normally provided. So crisis standards of care are not something you choose to invoke or you choose to start. They are necessary by the circumstance in which you find yourself. And that, I think, is the number one thing, because many people look for ways not to do crisis standards of care on the assumption that this is a choice that has to be made at some point. And it's not a choice, unfortunately. If you get to the point where you have to triage, it's because you actually have to triage. And of course, one of the key points in terms of planning for crisis standards of care is that it forces you to that very brink, right? It forces you to the brink and beyond to say, how can we possibly avoid having to make those kinds of tragic decisions? This is one of my favorite slides ever in retrospect, and it's a slide that Dan, our host today, put together for a workshop that we carried out in November of 2019. So less than a month before the first cases of COVID were to be identified in Wuhan, China. Dan said, these are the various disasters that had arisen since 2009. And then put these question marks at the end saying, who knows what might be coming next? And of course, you all know what came next. Only a few months later, we were seeing emergency rooms overrun in the city of New York, as well as emergency rooms and ICUs in Italy and Spain and in Iran and other places around the world. So a year later, when this summer came around, John Hick really led this effort, but with Dan, myself, and Eric Toner, we started thinking, so what have we learned over the last year? How do we ensure that values that are critical to uphold within a framework where, fairness almost seems like it's the wrong word, because no matter what you do, someone is not receiving potentially life-saving care, and that is unfair. But how do you ensure equity? How do we improve based on what we've learned in the last year? And I titled this slide, "What Were We Thinking?" because I have to say, this came out on August 30th, and almost immediately an email went around between Dan and John, and Eric, and myself saying,
so when you turn that off, these go off.
Hey, Dr. John Hick, you're on. Thank you.
So, and almost immediately upon publication, we started a little email chain saying, really, should we have called this "What Did We Learn?" Because it seems very clear from where we sit today and from what Dan just said in terms of where hospitals are at around the country, there are lessons we failed to learn, and we are still learning lessons about how to do crisis standards of care. So let me just say that we talked in the paper about equity, about political issues, about nomenclature, surge integration, coordination and sharing issues, alternate care sites, clinician roles, triage processes, supply chain, and staff shortages. And I'm obviously in my 6 minutes or 8 minutes here not going to touch on all of those. I just want to make 3 points. Number one of the things we have seen nationwide is tremendous reluctance to formally activate crisis standards of care. These are quotes from a report out of Eric's Center at Johns Hopkins about what happened in New York last spring, but we saw something very similar happen in Florida. And we are seeing this to some extent even today, where there's absolute chaos in hospitals, but the people at the top of the food chain, the people in the political realm or in the leadership, are not always willing to accept that, in fact, triage is having to happen within our facility. And when they do end up having to make decisions that are essentially triage decisions, some of the core values of crisis standards of care are not always being implemented. So back in last summer, when Arizona was really dealing with an enormous surge, they're one of the few states that formally activated a crisis standards of care plan. And the purpose of this plan, and this is at the top of this slide is actually a quote from the plan, establishing statewide standards to ensure all hospitals are providing the same level of care and patients are not being treated by different standards at different hospitals. That's a core sort of value of crisis standards of care, is ensuring equitable distribution of resources. This means load balancing across systems which are otherwise sometimes competitors, for example. And yet, when Arizona implemented or allowed for implementation of crisis standards of care, they did the same thing that we are seeing Idaho do today, which is to say they put it down to the individual facility to decide how and whether they were going to actually implement crisis standards of care strategies. So there's not statewide load balancing. There's not triage teams being established. It's up to each hospital to decide how they want to do this. So it's a value for the state to say it's okay for you as a hospital to implement crisis standards of care, and we're going to provide some legal protections in you for doing so. But it's not as much value as if there were also the other strategies that are part of crisis standards of care and that are there to ensure equity across multiple hospitals. So, sorry, that came on late, but the idea of devolving crisis standards of care decision-making entirely down to the individual hospital is a problematic practice. The last thing I want to say is that some of this is a result of challenges in the definitions that we put together back in 2009. The idea that there is a trigger point that is clear and that distinguishes between conventional care, contingency care, which is, and I'm putting this in scare quotes, functionally equivalent to usual standards of care, and then suddenly you're in crisis care, which is no longer functionally equivalent. And we realized even at that time that these were gray and that there were fuzzy borders between what you call contingency operations and what you call crisis operations. And we also realized even at the time that you might be in crisis operations with regard to your staffing, but you have plenty of space. And that distinction has sometimes failed us. The attempts to create that distinction may have actually put up barriers to people saying it's time now to implement this crisis care strategy, even though we are mostly still in contingency operations and trying still to provide functionally equivalent care. But with regard to dialysis, we are moving to limit those who are receiving dialysis, or we are limiting dialysis time runs and so on in ways that we know are potentially dangerous, but we have to do that in order to provide the best care to the most people. So I'll stop with that because I know I was supposed to only take a few minutes, and I will unshare my screen.
Great. Thanks, Matt. So while you're trying to figure out how to undo your screen, hopefully that'll be faster than how long it took you to get the screen up. I do have a question. As a director of bioethics and, with your long esteemed career, in the field, and as a writing partner and as a friend and a colleague, we've had the chance to talk about these issues many, many times. How should we think about the ethical framework in a public health emergency, in the crisis that we're experiencing now, as distinguished from thinking about more conventional bioethics or even public health ethics? Is there a distinction? Do the rules change? How should we think about this?
Yeah, I mean, so there are obviously distinctions, and at the same time, the core values that drive medical care and public health remain the same. What changes is how they end up having to be weighted in different circumstances. So it's not the case that under normal circumstances, we don't care at all about efficiency or equity, for example. We care about both of those things. It's not just, autonomy and whatever the patient wants. And in a crisis, we don't only care about efficiency and throw equity out the window, right? These are values that we hold in balance all the time. And in a crisis circumstance where you are forced to make triage type decisions, you do end up weighing efficiency and the efficient use of resources to save the most lives as a very important value. But again, that doesn't mean that you toss equity and autonomy completely out the window. Those things are always in balance. They're in a different balance. And of course, what people worry about is that someone will say, these are unusual times. These are extraordinary circumstances. We should only care about one thing. And that's probably a dangerous path, the sort of, extraordinary circumstances defense to doing something which would otherwise be completely unacceptable. Sure. I think we have to be extremely cautious about saying we're going to throw our normal ethics out because these are extraordinary times. We've seen that in the past, where medical care has been subverted essentially because of the extraordinary times defense. So I'm very cautious about that.
Sure, understood. Yeah, I think the one piece that I would add to that is, that in recognizing, particularly in the states, or locations that we've highlighted at the start of the meeting, Idaho, Anchorage, some hospitals in Montana, and so on. What we worry most about in pandemics is the collapse of the healthcare system, and the fact that that we are just incapable of delivering any care, either because staff just basically picks up and says, "I can't handle this," and we've seen a lot of hints of that already. And in that context, I just wonder whether the notion of promoting and protecting our health security as a fundamental pillar of our national security changes the calculus a little bit. And I think, we'll probably come back to that. So with that, thank you, Matt, very much. And now I'd like to turn the floor over to Dr. Jeff Dichter. Jeff is the Associate Professor of Medicine in the Division of Pulmonary Allergy, Critical Care, and Sleep Medicine at the University of Minnesota. Jeff is also the chair and or co-chair of the Task Force for Mass Critical Care under the auspices of the American College of Chest Physicians, and a longtime colleague. And Jeff's going to talk to us about patient load balancing, which is really one of the critical tools that we think are important in working our way through this current crisis. Jeff, over to you.
Thank you, Dan. Can you hear me okay? And are my slides showing the way I hope they are? Perfect, thank you. Jeff, this is Jeff Dichter from the University of Minnesota. It's a pleasure to speak with all of you today. Just a few comments about the Task Force for Mass Critical Care. We're really at an international group of experts, really very broad, doctors, nurses, therapists, many different specialties. We've been together for about 15 years, and we've of course changed over time. Some of the things we've contributed, we hope significantly, are CHEST consensus statements for disaster preparedness, particularly our 2014 statement. And much of what I'll have to say today will be a paper that was recently released online in the past several weeks, which really looks at system level issues with surge planning. I'll put this in the chat. I'll put the reference in the chat box as soon as we're done. And I think it dovetails nicely to the work that Dan and John have done and that we talked about earlier. So the most important priority here is trying to the degree with your resources will allow to stay within contingency care to avoid crisis standards of care. As Dr. Juanita had said, you end up in crisis because you don't have your resources. So short of that, what are the things you can do to try and prevent that and delay it? How do you use your resources to get there? Some of the current publications we've seen recently, which are referenced here, clearly demonstrate that under a severe surge, mortality increases strictly due to the surge. And we at first thought there may have been a learning curve early in the pandemic, but that's not simply so. It's any time during the course of this time that we've been under severe surge. And again, the most important objective is trying as hard as you can to stay within your contingency care limits. Some of the things we do, which are very common to virtually everybody on this call, how do you expand your ICU spaces to provide care? How do you expand your staffing models to provide more care? How do you utilize your equipment, whether it's dialysis equipment, whether it's ventilators, how do you utilize those things? And in this publication, we have, I think, 4 or 5, we have a case study with 4 or 5 different examples where we discuss how these things are used in a productive and effective way. And just to highlight what Dr. Juanita had said previously, is that it isn't a straight line between contingency and crisis. It's in fact an incredibly blurred line. And that blurred line really can vary day to day, and it can vary with different resources. This is from our 2014 publication. It's very similar to what was shown earlier. And the thing that I'd highlight is trying to stay within this middle column here, contingency care. And ideally, if we're able to effectively do this, it should have minimal impact on our usual practices. Typically, we think of this as being expanded up to about 100% above our routine care, and this is typically happening at a regional and state level. And through this pandemic, this has indeed played out in this way. The first item I'll talk about is really load balancing, which is really transferring using your coordination clinical centers, coordination communication centers to different hospitals to try and load balance the surge so that one hospital is in surge and other hospitals have capacity. You want to be able to move those patients from one to the other. And this is a generic diagram, but I think this is probably true in most states that have done this well. You may have your catchment center that crosses a state line, for instance. In Minnesota, we routinely work with our Western Wisconsin hospitals. And the other important point I'd highlight out is you're moving patients by ground, you may be moving them by air. There are lots of different solutions based on what your local needs are going to be. This has been done in Arizona, Washington, California, and Minnesota, where I am from. There are many other states that are undertaking this now. And some of the most important factors are all involving all of your stakeholders, your large health systems, your Department of Health, your state hospital association. It's imperative to realize that clinical people and administrative people have to work hand in hand to make this work. You have to have some idea of knowing where your beds are. Technology is helpful, but it's less important than actually having relationships and having people that can provide that information and knowing where the information is. It's crucial. And then again, transferring coordination across regions. Oftentimes, for instance, maybe knowing where the beds are may be related to a phone call that you'll have once a day or twice a day, but you have to have some means to be able to do that. And the other thing that I would be encouraging to most people, I don't think most states or regions within the United States have this. Outside the United States, I wouldn't be as familiar, but these things can be set up relatively quickly if you have all the key players involved and the wherewithal to go ahead and do it. Excuse me. I'm going to talk just for a minute or two about staffing strategies and really to think about your adaptive staffing models. Non-ICU personnel who can function in the ICU with help, who we affectionately refer to as our force multipliers. And one of the most important pieces we have found throughout this pandemic is really to embed your critical care professionals within representatives who are your non-ICU trained people. It's imperative. People have tried to do this by having separate teams and it has not worked well. And the other comment I'll have is to remember that we are in a marathon. This is not a sprint. There's always concern that organizations and ICUs can really be damaged if suddenly you reach a breaking point. Some of the recommendations are to try and limit overtime. 50% is a somewhat arbitrary amount, but to try and recognize that you have to conserve the resources of your personnel at some point, responsibly limiting documentation, planning for night coverage. But the crucial thing is to embed your ICU folks with your non-ICU folks and try and build a livable schedule for everybody who's involved in this. This is my last slide, and I'll speak briefly to it. We tried to develop models where you look at to the left over here, your provider staffing model, where your trained critical care people, your intensivists, if you will, can probably manage a certain amount. We've arbitrarily picked up to 12 patients a day. Those of us who are intensivists know that that's a pretty busy full day at 12. But how do you expand again to 100% above that, or 24 in this model? You need to be able to add personnel. The more experienced providers you have, the more likely you're going to be able to expand and care for patients. One of the things that we have found throughout this pandemic is the use of procedure teams. This has been a godsend in many places, and this comes in many different flavors. There are teams that are airway teams. Often CRNAs, when surgeries aren't being done, are wonderful to work with as airway teams to do your intubations. You may have people who are able to place lines for you, a line service. Oftentimes we've seen orthopedic specialists being the proning team for patients who need to be prone. But the important thing is to try and look at your resources and use them in an effective way to build capacity within your ICU. Tele-Icu support is important. There's many different ways to use this. My experience is often health systems will be supporting regional partners. And often something as simple as an iPad with FaceTime, if you're able to share a common record, may be all that's required to provide a huge amount of support to clinicians who are on site, providing care for patients who may not be able to be transferred, or at least not transferred immediately. To the right side of this is a nursing model. It's a team nursing model often that we've published, but often promoted by AACN. Given where we're at with our nursing shortage now, I'm not sure that this would have sufficient staffing to make it work exactly the way it's written, with one ICU nurse working with 2 other RNs to care for 4 patients. But the principle, again, of using your ICU folks as a base and filling in with others, I think is the most important point to be taken away from this. I'm going to go ahead and close there. I only had 8 minutes to speak, but also just wanted to really emphasize that, again, use the resources you have to the best ability you have to try and prevent that crisis level, or as many crisis levels as you can. And just great respect and regard for everyone out there. We're all struggling through this together. I am truly grateful for the chance to be able to share some of my experiences here. I'm going to go ahead and stop sharing my screen here. And our next speaker is, I can pull up my slide here, is Dr. Tenner Vanima from Johns Hopkins University, a professor there. And Dr. Vanima will be speaking to nursing considerations and other staffing challenges. Thanks, Tenner.
Thanks so much, Dr. Dichter, and thank you for your comments. Greetings, everyone. It's an honor and privilege to join you today to be able to talk about nursing considerations and some of the other staffing challenges that have really become quite clear, not only throughout all 4 surges of the pandemic, but what we are seeing Idaho, Alaska, and the 10 states that are running almost to less than 10% of ICU bed capacity. So to begin with, the pandemic has clearly demonstrated an urgent need for us to address challenges in how the US healthcare system mobilizes and deploys the nursing workforce during large-scale public health emergencies. And to Dr. Handling's point earlier, nurses represent approximately 4 million, the backbone of the healthcare workforce, and allow for business sustainability and certainly protect national health security by keeping our health system functioning and working at an appropriate level. However, throughout the pandemic, pre-existing nurse staffing shortages have been further exacerbated by the large influxes of COVID-19 patients, the loss of nursing staff due to quarantine after exposure to SARS-CoV-2, and COVID-19 related illnesses and death within the nursing profession. In addition to that, thousands of nurses have chosen to leave the profession, and many are intending to do so in the future. This has required hospitals to drastically shift how they staff hospital units, including upskilling of nurses, redeployment of nurses internally to new units, and a significant infusion of travel nurses. For example, hospitals implemented additional trainings for non-critical care nurses on ventilator management and renal replacement therapy to help build critical care nurse capacity. And while these actions were critical to augmenting the nursing workforce to meet the growing demands of the pandemic, there have also been many unintended consequences, including that mass exodus of nurses that we saw leaving their own home hospitals to become travel nurses. For example, some travel nurses at one point were making as much as $10,000 per week, well beyond what hospital staff nurses were compensated at. This has not only impacted the health system financially, but has led to divisiveness among nurses and departments of nursing, nurses who were working alongside colleagues with significant pay differentials. And finally, I think it's really important for us to acknowledge the mental health burden on nurses and other healthcare professionals who have worked throughout multiple surges. It has taken a tremendous toll, the full extent to which has yet to be known. So as we're limited today in our time, what I'd like to do is highlight what I think are some of the major issues that are present with respect to staffing challenges that we've encountered during the COVID-19 pandemic, and ask you to reflect on these and join us again on October 11th as we do a deep dive into each of these issues as it's related to staffing. So some of the issues that I want to highlight have really been revealed or have occurred as a result of the COVID-19 pandemic, many of which, however, were in existence long before January of 2020. So some of the challenges that we have witnessed have been an overall low level of emergency preparedness in our national nursing workforce. And having served as a senior consultant to AACN and through my research as a contributing scholar at the Center for Health Security, we have really studied how this absence of adequate education and training in pre-licensure programs, in graduate programs, and again, in the workplace has really limited our national nursing ability to mobilize, deploy, and to really put nurses in positions where they had the competencies, the knowledge, skills, and abilities to do what we needed them to do at that time. We've witnessed a lack of elasticity in hospital staffing patterns, resulting in an inability to pivot quickly to reassign nurses to COVID-19 units. And Dr. Dichter just reflected on that. It's not just load balancing patients across hospitals and health systems, but I think we need to start thinking about education, training, mobilization, and deployment of nurses, both internally and externally, in order to meet the needs of the healthcare system. There may be a lack of understanding and an appreciation amongst some for the time that it takes to educate and train a critical care nurse. This is not something that will be solved by just-in-time training. There are limitations in hospitals' capacity to rapidly upskill nurses. And as I've mentioned, that inability or unwillingness to load balance nursing staff across health systems or regions. And this may result from a lack of communication or memorandums of understanding up to licensure and certification restrictions across state boundaries. We have seen in some webinars that AACN sponsored last year that there really is a significant lack of awareness or understanding of what crisis standards of care really mean in the nursing profession. And so I think that's a gap that we need to think about how we're going to address. Nurses have also been burdened by a lack of support for child and elder care and help with home service support throughout the pandemic, allowing them to work these increased hours, doubles, triple shifts, and as such. We have also seen the incidence of moral injury to healthcare providers and nurses in particular, who really have struggled with, as they move beyond or toggle beneath contingency and crisis standards of care, that inherent really moral distress that a nurse experiences when he or she recognizes that they're not able to render the level and quality of care that they normally do. I also want to acknowledge that the nursing shortage that we are experiencing now predated COVID-19 and has only been exacerbated by the multiple issues that I've mentioned so far. Some of these really warrant a deep investigation and a review of what I would consider are somewhat antiquated systems of recruiting and hiring and sustaining nurses in the profession. Hospitals and healthcare centers have really failed to view nurses as talent and to recruit and develop and establish career advancement ladders and initiatives to really grow and sustain a nursing workforce that will be happy and satisfied and not experience the burnout and some of the distress and discontent that COVID really revealed. I also would like to sort of have us think about the national nursing workforce from more of a 30,000 foot level, and just acknowledge that we do not have a national nursing database. Each state board of nursing maintains its own database. However, there has been a historic reluctance for those state boards of nursing to share data and be able to really create a national nursing database where we would have a much better idea of exactly how many nurses we have, what their subspecialty training is, what their competencies are, and would help us in our disaster and pandemic planning for future events. And of course, our DMAT teams do have registered nurses and nurse practitioner participants, but we have seen the limitations in the ability to deploy those federal assets, and keeping in mind that those nurses have regular jobs and are volunteering above and beyond their regular hours, and that there's a limitation in the amount of contribution that the DMAT teams are able to provide. So in conclusion, I think I just want to say that this is a pivotal moment for us in the COVID pandemic, as it offers an unprecedented opportunity for us, first of all, to learn from the facilities who have had to address and overcome nurse staffing issues in order to ensure the continued functioning of the healthcare system. It offers us a wonderful opportunity to critically look at the way we finance the profession of nursing in the United States. The traveling nurse situation revealed the perversities of listing and bundling nursing on the cost side of a hospital's balance sheet as opposed to a revenue generating side. And because of that business plan that we use, it has really resulted in unanticipated consequences that we will now be faced in the future to address in terms of pay equity across nurses and hospitals and health systems and traveling nursing organizations, and to really look at how hospitals are going to finance their nursing staff going forward. So I believe that we have, again, a wonderful opportunity to really look at the lessons learned. These can be used and will be critical to us building a healthier, more resilient, and stronger healthcare system, certainly building stronger national health security. And that includes having a national nursing workforce that can be deployed and immobilized and deployed to areas of greatest patient need in a quick and efficient manner that aligns with our framework for crisis standards of care. So on that note, I'd like to thank you, and again, really encourage you to join us on October 11th for our webinar, where we will specifically address staffing issues throughout COVID-19 and in future pandemics. So on that note, allow me to turn it over to Dr. Christopher Newton, who's going to talk to us about pediatric crisis standards for care.
Okay, thank you very much. Hopefully my screen is up and you can hear me. I'm Chris Newton. I am a pediatric surgeon at UCSF, and I happen to also be the PI for one of ASPR's two pediatric COEs. These are the pediatric disaster regional centers. I run the West Coast Center, and of course I have a counterpart in the Eastern Great Lakes Center. And that, of course, is how I got involved in this discussion over the past several weeks. There we go. So thank you for including pediatrics as part of this discussion. Let me set up by stating up front that I think a lot of the issues and concerns for pediatrics overlap with everything that has already been said. So all of the ethical foundations that Dr. Wynja was talking about and the considerations are the same for adults as they are for kids. I will also note that a lot of the pediatric considerations are extremely community dependent. It is highly dependent on what you have in terms of resources as well as in terms of challenges. So considering that, I am going to try to not repeat everything that's already been said. I am also not going to be able to give you general universal plans that are going to be implemented in every place of the country, because that's not honest. What I do want to do here is at least highlight the considerations that we've been hearing from all sorts of folks all over the country, and some of their solutions and best practices and some of the tools that are specific to kids. All right, so let me start with specific pediatric challenges. I'll note at the very top, and in some ways this is stating the obvious, there is with every child a guardian or parent, and that creates a dynamic that is a little bit different, because stating the obvious, usually those parents will give up their own spot for their child and do anything for their child, and anything less than that is just not acceptable. And this creates a challenge in many environments. The other thing that I will note with kids is all the considerations of space, staff, and stuff, and all of the scoring algorithms. When you look at the details, there are some subtle differences that you have to take into account. And you can see some examples there. ECMO in a child is not necessarily the same as ECMO in an adult, nor does it have the same equipment demands. So when talking about load balancing and sharing of resources, your local community needs to take these into account. And as talked about before, not every disaster is the same. Currently, of course, we're in a protracted environment, very different discussion, from an acute event. And so I don't want to confuse those two discussions. All right, so over the past many weeks, our group has received tons of requests for help and concerns as individual communities began to try to implement crisis standards on some level, whether it was declared or not, and quickly ran into concerns and anxieties about what do we do for the kids? Because a lot of the plans that had been written, when you begin to go to the bedside and practically implement this, it was not good and not acceptable, and they needed to pivot. So we, as we got all these requests, responded with, let's pull everybody together and share what are the concerns for every community and what solutions are people doing. And a lot of these solutions you've already heard about, and Dr. Dichter was talking about a lot of the details of what they are. So we had ad hoc Zoom, open mic webinars for doing this. And I'll summarize a lot of the discussions. Universally, as has already been mentioned several times, everybody agreed the best solution is prevention, and staying in contingency mode is where you want to be. Load balancing and EMS adjustments across your system are critically important. However, to do that, for kids in particular, you need to integrate some special pediatric resources like subject matter experts that can advise you on the equipment and the stuff and the requirements so that you know how to load balance between facilities appropriately. There was also a theme in all of these discussions that as you write down your policies and you try to implement them, that altering the verbiage so that you are emphasizing what you are doing for the kids and what you can provide. And you are emphasizing that no child, and I could say adult as well, no patient is going to be abandoned. You are not going to provide no care for anyone. It is important in the verbiage of your policies to illustrate what you are doing. So we took all of these comments, all of these specific practices, we put them in a table, and we are happy to share this. We've been sharing this with anybody that asks for it. The definitions and triggers and things that you are seeing on here, this comes directly from all the National Academy's work that's already been done. So this is not replicated or different. And a lot of the bullet point suggestions that various communities are doing have already been talked about. We just put them in a list and gave the pediatric perspectives from them. And you can see the examples of what I'm talking about. And I just listed a few of the contingency suggestions. Many of these already talked about. How do you load balance? How do you switch your EMS traffic so that 15-year-olds can go to either an adult or a pediatric center? All good practices, all these little bullet points put together will help you a lot. All right, I want to illustrate a few of the specific pediatric tools that are out there. And number one is to acknowledge in 2019, the healthcare coalitions across the country had a mandate and a push to develop a Ped-Surg Annex. This was a project that predated COVID-19. What this means, however, is that almost all communities out there have a plan that's written down that should document some of your local resources. If you have not found that plan and haven't looked at it, you should. The other important resource is the National Peds Ready Project, which just got through doing another national survey for capabilities. This is a project that encourages ERs around the country, Peds or not, to identify Peds champions in their facilities. If you have not found that individual in your community, you should hunt them down. All right. The next resource that I will mention is telemedicine. Telemedicine, of course, is a tool that is adult or Peds. It's not specific to us. The interesting niche for children, however, is there has been this tremendous explosion over the past 2 years of telemedicine shifting from provider to provider infrastructure over to provider direct to patient infrastructure. This means that your special care needs and kids have direct access that they didn't used to have. And your medical homes, your pediatricians' offices are connected to their patients more than they ever have been. This is a new development, and in many communities, it's just not being utilized as much as it could be. It's not going to replace an ICU. It's not going to take the place of acute care, but it can force multiply your system and potentially help you quite a bit. I'll list several sources here. I provide this just for reference. We've gotten many requests for how do we train an adult doc to take care of a pediatric patient and vice versa. I will acknowledge this has been happening all over the country in many communities. There's lots of papers and manuscripts and academic articles out there on experience over the past year in doing this. Several sources that provide just-in-time info to help cross-train. and give people skills and info and resources that you don't normally use. The final reference I will toss out is we have worked a lot with this organization. This is the Network for Public Health Law. James Hodge and Jen Pyatt helped put together this flow sheet that we reference all the time, and we include in a lot of our documents. Great resource. If you haven't looked at it, this is good stuff. So in the interest of time, I'm going to stop there, and I look forward to panel discussions. All right. So I think following me is Monica Peak, and I will stop sharing my screen and let Monica start.
Great. Thank you so much. My name is Dr. Monica Peak. I'm an internist and a bioethicist at the University of Chicago. And I'm also the assistant director for the McLean Center for Clinical Medical Ethics. And so I'm going to be talking about ethics and equity considerations, which is something that's extremely important, but something which we haven't given enough consideration to. And so I'm hoping that this presents an opportunity, given all of the tremendous disparities that we've seen with the COVID pandemic, for us to hunker down a little bit more and think about that. Next slide, please. I'm going to level set a little bit just so that we're all on the same page definitionally, thinking about what structural inequities mean. And so by definition, those are policies, laws, procedures, and norms that differentially limit the access to goods, services, and opportunities. So things like segregated schools, residential housing that's segregated, discriminatory banking and lending practices, unfair criminal justice policies, unequal access to basic human needs like food, shelter, etc. Next slide. When these inequities, we know that they're not randomly distributed in the society, that they occur along fault lines based on social identities that are marginalized. So those social identities with less social power have less access to these goods, services, and opportunities. And so there's a list here that is not exhaustive of various kinds of social identities that all of us may carry. The one that has the most power, most powerful salience in the United States is race. And so when we think about structural inequities or differential access to goods and services because of race, that's called structural racism. Next slide. And so you can just start tacking down all the bullets here. So we know that based on the number of the kinds of structural inequities I had just mentioned, and you can just keep hitting the bullets, there have been a lot of associations between a number of chronic diseases. This list is not exhaustive, and the number of publications that will be shown at the bottom also is not exhaustive, but it just gives you a kind of sort of sneak peek into the way in which the built environment, the social environment, discrimination, things like that work to mediate and moderate how people ultimately come to have poor health. Next slide. Next slide. So when we find ourselves in a situation where we have activated crisis standards of care, in emergency situations, we are balancing multiple ethical principles, some of which include things like maximizing the benefits, in which ultimately healthy people might do the best. We may be thinking about maximizing life years, where those who have the most years left may be at a more disadvantage. So thinking about the youngest among us. But we also need to consider equity, where those of us who have been socially marginalized may have worse health because of historical and contemporaneous structural inequities that have made those populations have worse health to start out with. So how do we try to equitably distribute finite resources, given that some may start out with worse health for reasons that are not their fault. For some that may have already aged through many of their life cycles, but knowing that we also want to maximize benefits. How do we sort of balance all these all these ethical principles? Next slide. So next slide. So I'm just going to walk through a few studies that have come out relatively recently. This came out in blue just last week, called the Simulation of Ventilator Allocation in Critically Ill Patients with COVID-19. And the senior author was a pulmonary critical care physician and bioethicist here at the University of Chicago. Lots of wonderful colleagues. And so what we did was do a simulation of many of the crisis standard of care model allocation protocols for ventilator allocation. Next slide. Using multiple different kinds of ethical principles. So using a randomized lottery, using a youngest first, which they do in some countries like Italy, using a SOFA only, where SOFA is the sequential organ failure score is used to predict mortality. Some countries use that only. Most of the systems in this country are based on the SOFA score to some degree. And then there's a multi-principle, which uses SOFA and then may have age as a tiebreaker, or may have age and may have added comorbidities and then have age as a tiebreaker, things like that. And so the things that I want to draw your attention to are how in the lottery, allocation, which is the sort of the left three columns between Blacks, whites, and Hispanics, was equal. And you find that in the lottery system, the survival, which is the left three columns, were approximately equal as well. But when you used SOFA scores, which are predicting short-term mortality within the ICU, you'll see that there are statistically significant differences between Blacks and whites and who was allocated a ventilator in this protocol. And also, you'll see that there were significant difference amongst Blacks and that they were deprioritized to receive ventilators with the SOFA-only protocol. Next slide. This was a study that came out earlier this summer with some of the same authors, including myself and Dr. Parker, in JAMA Open. Next slide. And it was specifically looking at SOFA and its ability to accurately predict mortality. And what the top slide shows is sort of the distribution of SOFA scores by race. And what the bottom shows is how accurate that SOFA prediction is with mortality. And what we found is that essentially Blacks, when you compare them to whites, were systematically deprioritized, that the SOFA score was not as accurate as we thought it would be in predicting mortality, and that for a given SOFA score at the very low rates where people had a high chance of getting a ventilator, that Blacks actually had a better survival rate, but were predicted to have a lower survival rate. Next slide. And what this ultimately meant was that many patients, thousands of patients, would have been deprioritized or kept from having ventilator access. Next slide. And so there's a study that looked at factors that were associated with death in critically ill patients. And and what we found is that once people were admitted to the hospital, there were no differences between Blacks and whites. But next slide. One of the key differences was whether or not the hospital had a high number of ICU beds, which leads to the third issue about the transfer system and how the inability for community hospitals to be able to transfer in to tertiary centers led to a lot of the disparities that we saw during this pandemic. Next slide. And so there was a paper that came out this year in February looking at strategies to mitigate inequities and saving lives with ICU triage during the pandemic. Next slide. Some of the things they recommended were modifying the existing triage guidelines. So first, using a correction factor to reduce the impact of structural inequities. So adding a few points if you came from a zip code that had some of the highest rates of area deprivation, giving heightened priority to frontline essential workers, all of them, not just healthcare workers, and particularly not using long-term life expectancy. So if someone we thought would die within the next year, that would be different than using sort of chronic diseases and significant comorbidities. And then last, considerations at the state level, doing things like developing robust inter-hospital transfer mechanisms that we don't currently have, that keep overwhelmed safety net hospitals from transferring patients to better resourced hospitals. Next slide. That's it. That we could go into all of these in more detail, which we will in future sessions, but I just wanted to start us in the thinking process of how to begin thinking about equity and some of the solutions. Thank you so much.
Great, thanks. Thanks very much, Monica. And thanks to all of the panelists for your excellent presentations and actually keeping us pretty much right on time, which is kind of remarkable. So that is tremendous. And so now, as you have seen, we've tried to, there have been some great questions coming through the Q&A, so thank you for those questions. And we've tried to sort of bang out some answers, you know, to sort of get the conversation started. But we're at the point in our discussion now where what I'd like to do is circle back to, you know, to some of these questions and see if we can get some additional answers to you. I had hoped that John was going to be, that John Hick was going to be on, but I don't see him and he hasn't answered my text, so I'm guessing he got called away to do something else. Question that I was going to frame for him was back to Matt's comments at the very beginning, which is not what have we learned, but you know, what do we continue to need to learn going forward? Maybe we'll come back to that. There were a number of other questions. Another question that I was going to address to Jen Piat, who also had to step away, came from Dr. Schneider from our emergency College of Emergency Physicians, American College of Emergency Physicians, about the recognition of crisis standards of care by CMS, and particularly the opportunity for changes in documentation that, of course, may have downstream consequences with regards to reimbursement and so on. So I believe that Jen put into the answer, I hope that she did, some of the information regarding 1135 waivers, which include the opportunity for EMTALA suspension. But clearly that does not get at the full array of problems with regards to, you know, potential effects on reimbursement. So I'd like to open it up to the panel. How have any of you addressed some of the challenges around documentation, particularly during surge, recognizing that documentation is key? We need it even just to be able to take care of a patient and share information amongst ourselves as doctors and nurses and other clinicians. But how have you managed the documentation challenge, and any insights that you can provide? Any takers? No takers? Okay. All right. Well, go ahead.
So
Matt.
I can't really answer the question, but I will make a side comment to the question, which is, if there are strategies that effectively reduce the documentation that is not necessary for actual patient care, we should be implementing them, and not just during the pandemic. So I think this is one of the ways in which the experience of the pandemic may actually, you know, we may come out of the other side of this with a better, more efficient, more humane healthcare system, if along the way we look at things like documentation requirements and say, you know what, some of these documentation requirements were really all about billing.
Right.
And
right.
To the extent we got rid of those during the pandemic, why are we making people do that after the pandemic?
Yeah, there's no question, you know, if there's a silver lining in all of this tragedy, it should be that we are improving our systems, that we are improving our capabilities, and that in looking to the future,
yeah,
particularly from the vantage point where I sit right now, that we're going to look at, for example, technologies that can assist us. I think Chris and Jeff both alluded to telehealth, telemedicine tools, which of course had always been in existence, but weren't pressed into service until we really needed them. And we realized just how effective and efficient they were. So if there is a silver lining, the silver lining is that we make tremendous improvements to our healthcare system going forward.
Yeah,
any other comments?
Well, Monica's point earlier about the load balancing and the challenges there in terms of the equity impacts of the inability of hospitals, that's not unique to the pandemic, right? Before the pandemic, there are places that get full and say, sorry, we can't take your patient, even though that patient will end up suffering a worse outcome because they can't make the transfer. And that was completely, pretty much up to us to make those decisions. Right. Insofar as there are relationships forming between the CMOs at different systems and load balancing is being used efficiently in some places and is alleviating inequities, I hope some of those also will continue on beyond the pandemic.
Absolutely. So I do see, John, I do see your name back up. I'm not sure if you're able to join us or not. I got a note that you've got an issue that you're dealing with. If not, then I'd like to open the question more broadly, an excellent question that was put in the chat by Jeff Rubin, one of our esteemed colleagues. And Jeff asked, how do we, going forward, how do we emphasize the implementation of crisis standards of care planning? We put a lot of plans in place. How do we get others on board? And I know as a planning committee, you have begun to think about that. Any thoughts or ideas about what we can do going forward to ensure that we are focusing on implementing these plans and implementing them in a transparent and equitable and useful manner?
Yeah, and I guess what I would add here, this is Jeff Dichter, is that I think working at a regional or state level, a healthcare coalition level, I think is really important. To be able to work with your colleagues and your partners and start to really look at the issues and how you're going to start to manage these together. If there's something we've learned from, I believe what we've learned from this pandemic is that working separately as hospitals or individual health systems is really not as helpful and counterproductive to the greater good. And I think even those of us who are within it have found this. I know Eric Toner in his publication about the New York City hospitals, I've heard them say this time and time again that they were all like islands during that surge and they wish they could have found each other and others to help them with it. So that would be one of the most important pearls that I would add there.
Great, thank you. Excellent point. Other insights or thoughts?
I would say two things. When I was a public health student, we were talking about crisis planning and no one seemed that interested, except for those who are really interested. But I think now, in the middle of COVID, everyone is interested. And so I think we have a better opportunity because everyone has skin in the game right now. And so I think it is more about using the communication channels that are there to get information out to everyone more so than trying to rally the troops to have them listen to our call. So I think that there's a different level of interest now. But the other thing I would say is that even though we knew from patient experience and as per frontline providers that the best thing for our patients was for physicians to cooperate and that there were journalist advocates doing the same and some local politicians who were interested and even, state level and federal politicians that were interested. I think politics work slowly, but it's going to take that level of push. I'm not convinced that the hospitals couldn't find each other. I believe that the payment mechanisms are going to have to line up for it to make the right thing to do, the easy thing to do. And that is going to be the work of realigning some of our policies and putting that in play to make sure that it's easier for the hospital systems to collaborate.
Yeah, great.
And just
just to follow up on Dr. Dichter's comments and Dr. Peek's comments, I do think that this is a place where the convening function of state and regional government politicians can make a huge difference. And we saw that with the variability around the country. And I do think that one of the things that we need to do sooner instead of later is to work with the National Governors Association, work with the National Association of State Health Policymakers, and say, where did that convening go quickly and actually address some of the issues that Monica just highlighted, and where did it not occur at all, and where was it everyone for themselves? And I think that will provide a template for us to move forward a little bit more efficiently than we have thus far.
Yeah, that's great. For 3 years, I was invited by Illinois Department of Public Health and the City of Chicago Public Health to help focus on city and statewide planning for crisis standards of care, along with Dr. Suzette McKinney. And, the one thing that we never were able to accomplish was kicking off what we called an elected officials toolkit. In other words, getting our elected officials to understand that crisis actually ultimately resides on their desks, and that the decisions that have to be taken can be greatly influenced. And of course, in the interim, since those days of planning, we've had 4 years of tumult in U.S. national politics. We've had this pandemic, which has been most divisive. And I think it speaks even further to the importance of doing that sort of education to our elected officials and getting them on board with understanding the complexities, the frailties of the existing system, and the need for their voice and their input in helping us to adjudicate these uncharted waters, these difficult waters. So with that.
This is Anuj Mehta. I'm an intensivist in Colorado. I'm really taken aback by the nature of this conversation, where so much of what we're talking about in this first question in the panel discussion is not about crisis. It's about how a lot of these issues, staffing, inequities, how we view public health at the local versus state level, were pre-existing before the pandemic. And Dan, you mentioned the divisive nature that the pandemic has played. And I think what's really going to be important is, as we frame this discussion, we make it less, obviously there are specific things about the crisis that we need to talk about with the pandemic, but as we move forward and think forward and prospectively, framing this as a pre-existing problem that was only exacerbated by the pandemic. Inequities existed well beforehand. We were in a critical nursing shortage well before the pandemic, and it's only been made worse now. And how can we rethink some of these ideas? And I'm really struck by, kind of throughout this pandemic, the lack of funding to public health agencies, and the fact that we really have ceded for the last 50 years, ceded control of public health decisions to local control, which are heavily influenced by local politics, and how that has really led to regional inequities, both within states and across states, and how that's perpetuated so many of the issues we've had with the pandemic. And so I really urge all of us to think about this as like, this was a problem way before COVID, and this is going to continue to be a problem even if we invent a magic pill that can cure COVID. And really, we need to think about how we can reallocate and rethink our fundamental infrastructure.
Yeah. Well said. I think we're of the same mindset, and clearly what I have described COVID as sort of the unroofing of the blister. The blister was there, and we broke it, and now we're dealing with that raw underskin, that exposed dermis. But being such as it is, let's try to focus a little bit more directly on some of the solutions, if you will. And there are a couple of excellent questions in the chat that I'd like to address to the panel. The first has to do with what we have recognized as really an inability to use decision support tools. The one that received the most attention, and that really is probably replicated in many, if not most, crisis standards of care plans, is the SOFA scoring tool, the sequential organ failure assessment score. As critical care physicians, or as others who are providing care and thinking about triage decisions, what does the future hold with regards to being able to get smarter about deciding who would be most likely to benefit from critical care resources? Any thoughts or insights, or are there any supporters of SOFA?
You know, let me comment about this real quick, and I want to expand your question to include the PLOT. So the PLOT is of course the pediatric score that that mirrors the SOFA, and in my conversations with multiple different institutions, a lot of the practical difficulties in using the score to make decisions. It's academically great, but it's impossible when you go to the bedside. And folks are saying, we can't do this. And the solutions, one of, I think, the more ingenious discussions that I heard was integrating an ethics committee that was institutionally based. So at one facility that is an advisor, that has an advisory role to your HICS committee. Now, what that advisory role does may depend on what the question is, but implementing ethics into your HICS team, I think, was a novel solution at several institutions, and replacing a score with a committee.
Yeah, great. I think that at the end of the day, back to the earlier question about implementation, the challenge of implementation, it is not easy to make those decisions. And in fact, in the 2012 report, we wrote extensively about triage teams and having an appeals process, and in the heat of the moment, it's easier committed to paper than it is committed to the bedside. So I think that we need to continue to explore this issue. Anuj, thoughts on this?
Yeah, it's interesting as an intensivist, we have lots of scores like SOFA, we have the Apache score, and there are several others, and they're used in research all the time. They're used to risk adjust clinical trials or stratify clinical trials. We never use them clinically. We always look at a patient, and when we're talking to family members about the likelihood of survival, we kind of use our gut. Now, in terms of making triage decisions, I don't think that's appropriate, but I was really, I was taken aback when I saw a JAMA paper that suggested or demonstrated how age in and of itself performed better than SOFA at predicting short-term mortality for COVID-19 patients. And it really highlighted the fact that these scores were not developed to do what we asked them to do. And we're also developed at a time where our computer-based skills, machine learning algorithms, and other advanced big data type systems were not really being utilized. And I think that's a potential point that we can think about moving forward, is how can we really look at electronic health data to develop new scoring systems with a specific goal of triage. Hopefully we never need that, right? Hope that's like in our back pocket, but with the way that certain electronic healthcare records are now expansive across multiple systems, pooling that type of data, and again, this takes leadership that goes well above a hospital system because they want to protect that data, potentially has the ability to arm us better for the next pandemic. Although I will say that oftentimes what predicts mortality for one disease will inherently not predict mortality for the next disease. So the next question is, how can we repurpose this rapidly for the next pandemic, for the next infectious agent, thinking about that. I also think that one of the things that Monica raised about how the SOFA score alone, poorly selected certain specific populations goes inherently to certain biases that exist within healthcare. And, specifically with the SOFA, the creatinine clearance has certain racial and ethnic biases. And so we need to think about what types of things we're incorporating and where some of the structural racial views that are entrenched in medicine, where they may be affecting some of our decisions, and how can we remove that and what the impact of that is, and make sure that we have key stakeholders in those types of discussions.
Yeah, absolutely. And two things to say. One is, I think, the SOFA was, we talked about this going all the way back to the early meetings that Jeff Dichter hosted in anticipation of the series of monographs that were published under ACCP back in 2014, that SOFA, was really a comparator, but not a discriminator. And, and there clearly are limitations in its application and its use. And I wholeheartedly agree that, man, we generate a lot of data. It's time for us to start running that data and looking at it and getting smarter, not just for pandemic response, not just for COVID, but across back to the point of improving our capabilities sort of writ large, and improving the outcomes that we deliver as healthcare providers. And I think we're on the cusp of, whether it be applying AI and other sorts of, mathematical models that allow us to have a better sense of a large database, and use some of those insights to better tune what we at the end of the day have to make as decisions at the bedside. So we'll never replace that, but perhaps we'll be able to learn from this experience in terms of getting smarter. Let's see,
Hey,
Matt. Yep.
Sorry,
Matt.
John.
Oh, John. Well, John, go ahead. John, and then Matt, and then
I just want to tag off the SOFA discussion just because I was kind of one of the prime instigators of using SOFA with the original paper that was published on that. And I just want to agree with Samir that SOFA was never meant to be an independent discriminator. And Dan, you and I have seen in a lot of state plans that it's about the only factor that gets considered, and that's absolutely wrong. There is some general help with scoring systems that allow you to look at degree of organ support and degree of criticality, but the most important factors have to do with the prognosis for whatever disease state the patient has. And as much as I respect and agree with Chris about the engagement of ethics, I think ethics needs to be involved not as much on a case-by-case basis, but to establish a firm ethical foundation for the choices that need to be made, especially around non-beneficial care. That's not the same thing as futility. But deciding when we get to a point of non-beneficial care and how we decide as providers and as institutions when we get to a point of having that be the standard, rather than futility, I think is really important to these discussions. But I sympathize, about the fact that there's not a lot of really good predictors out there right now. But good, well-trained, critical care physicians often can help a lot in consultation, with a lot of these patient transfers, not only from a withdrawing support standpoint, which is extremely rare. And I think people want to go there with crisis standards of care frequently, and rarely is this about withdrawal of support. It's usually about prioritization of which patients for the assets that we have are going to give us the most for our investment. So I'll stop there, and my apologies for jumping in. Thank you.
Yeah, thanks, John. So Matt, did you have something to add as well?
Well, I was going to complexify the problem of SOFA and
don't complexify. It's already so complex.
Well, I think it is true that we, through AI, because we've done so at our system, we can make a much more accurate predictive algorithm of who's likely to die despite the full court press. And we implemented that at our place for a while to sort of test it. We never fortunately needed to use it for a triage decision, but we can make pretty accurate predictions, much more accurate than SOFA, about who's going to die anyways. And if you were to use that in making triage decisions, you would disadvantage populations that are historically disadvantaged, because in fact, they do have higher mortality within our healthcare system today. And there are many, many reasons for that. And I think one of the things that this scoring systems bring up is, is efficiency, saving the most lives, the only value that matters? Because if it is, then it doesn't matter that most of the resources will end up going to wealthy white people, because gosh, they have longer to live anyways, right? It's very reminiscent of the early decisions we were making about how to allocate vaccines. And, there are neighborhoods that are primarily minority where the average life expectancy is under 75.
Yeah.
So no one's going to get the vaccine early, even though that's the population that is most at risk of dying from COVID.
Right. Yeah, there's no question, these issues are fraught with complexity. And actually, we've been getting some excellent questions from one of our other colleagues, Doug White, who's been asking some very appropriate questions. And in the literature, I think Monica alluded to one of his papers earlier, has been calling for using some of the other social determinants of health to help sort of adjust and make determinations with regards to potential access to resources. Actually, I think Doug and Bernard Lowe and John and I have a counterpoint piece that we're working on now to address some of these issues. There's no question, writ large, I think we are all in agreement. We need to do a lot more to improve healthcare delivery and access to care for all. And, again, what this crisis has demonstrated is where those inequities begin to shake out with regards to poorer outcomes, worse outcomes, greater burden of disease in any given community. And we must take from this experience those improvements going forward. So let me turn attention, we have about 30 minutes left. Let me turn attention to another critically important point that's come up in a number of questions. And that is the point of load balancing. And I'd first like to ask Erin Serino to address Robert Farnham's question about load balancing and the role of EMS. And where does EMS fit into all of this? A critical partner in all our work in crisis standards of care. And then I'd like to turn to Sherry Fink's question that was put in the chat about examples of states or other regions where load balancing seems to have been relatively successful, if there are insights or ideas in terms of where things have gone well. So think about that question, but Erin, turn it over to you in terms of how do we get EMS engaged here, and particularly around load balancing.
Sure, thanks Dan, and thanks Robert for the question. By way of introduction, my name is Erin Serino. I'm the Deputy Chief of Staff at Boston EMS. And I think to point towards the EMS staffing challenges question that arises with load balancing, as Tenor said with nursing across the country, we are seeing shortages of EMTs and paramedics, so we certainly do need to take that into consideration. But we're talking about load balancing both in the planning process, but then as we look into the implementation of crisis standards of care, I think it's imperative that our EMS partners are at the table, that they're tied into, whether it be through a healthcare system or a healthcare coalition, that there is that partnership and involvement for the coordination of care across the entire system.
Yeah, great. I mean, I think, again, a lot of this takes me back to the early days after 9/11 and the anthrax attacks and so on, to the conception that I had of healthcare coalitions, the fact that you had multiple partners, all of whom had to work together to achieve a certain outcome. And I think that this is, this is case in point with regards to the role that EMS has to play. And again, remember, we're talking about shortages at the bedside. I mean, our EMS systems, particularly those that are based on volunteer services or in our more rural communities, are extraordinarily, tapped out with regards to access to service delivery. And we have to think about how crisis is affecting their ability to do what they do as well. Thoughts from the panel in terms of examples of successful load balancing? Are any of you aware of efforts that have been put in place to some benefit? Chris?
Yeah, I'll just comment, especially once again from the pediatrics perspective, that some of the, I think, more successful changes are sometimes very subtle and don't discount small efforts. So, for example, any given community, defining what is the age cutoff for a child versus an adult, and shifting that age cutoff by 1 or 2 years is generally not putting any child at risk or adult, but can shift your volume sometimes tremendously. Small change, big effect. I know one county that made a very tiny rule change that allowed in-field paramedic teams to decline to transfer someone that they thought was completely stable. Historically, that would never be allowed. That one small change relieved pre-hospital tremendously and allowed them to survive.
Yeah. Yeah, well, I mean, you know, again, in crisis, we take hard choices. We make difficult decisions, and you know, we do it, from my perspective, ultimately to maintain our health security, to maintain a system that functions. And it's implicit in everything we've said. It's understood, but I'll call it out here just because we haven't done so yet. And that is that we're not just taking care of COVID patients. We're taking care of heart attacks and strokes. We're taking care of trauma victims and pregnant women, you know, who are coming to deliver. I mean, we have the whole, you know, spectrum of healthcare service delivery that we have to maintain in addition to what we're dealing with now with regards to this respiratory virus. Jeff, any thoughts or comments from the Minnesota perspective?
Yeah, I think in general, I think the load balancing that we've looked at a system level between institutions using, again, paramedic resources. I think early on in the pandemic, there were many good examples that were successful. The four that I've mentioned in my slides: Washington, California, Minnesota, Arizona. My impression at this point in time, as the surges have increased now, as our resources have somewhat decreased, particularly nursing resources, our nursing care, as we've talked about so far, I think that that's becoming a strategy that's more difficult to be successful with. There's less resources and load balancing is becoming more difficult. I think other, you know, looking at staffing strategies, for instance, are probably the next step to try and improve capacity or increase capacity. But I do think it's successful, and I would encourage all regions and states to continue to look at their opportunities for load balancing across institutions and systems.
Yeah, and I want to highlight again, you know, Doug White's comment, and I think there was a question earlier about, you know, the fairness. For example, big, robust, you know, successful, economically successful systems may elect to maintain elective surgeries for their in-network or, you know, their own patients because that's revenue generating. And I think in crisis, I think the rules change. This goes all the way back to my original question to Matt at the top of the last hour, which is, ethically, can we say that the conditions are such that we actually make some slightly different decisions? In this case, with regards to load balancing, you know, saying, look, I know that you're generating revenue by doing your elective knees or hips or what have you, but we've got a system that's on the verge of collapse and we've got limited resources. And yes, we need to take patients from farther afield who are at risk of dying at the very present time. I mean, these are extraordinarily challenging points. And this, I think, ties to our earlier discussion about having, you know, political buy-in, having a sense of, you know, at the state level and at the intrastate level, coordination. When you go back and you look at the 2009 letter report, that was the report that kicked all of this off in the interim between the first and second wave of H1N1, when we thought that was going to be the big crisis that we were facing. We put forth, you know, 5 or 6 key recommendations, you know, all of which are relevant today. And one of them was ensuring that there's interstate and intrastate consistency, consistency in the delivery of care, which really was the precursor to our describing load balancing. But I think if we go back, you know, if that's the Bible, and if you believe in that, you know, then those are the words that should be, you know, adhered to, and the principles should be held to in the context of what we're trying to achieve. So,
yeah, Dan, if I could just comment, I had written to Doug in the chat box. Doug's question is a really important one because it really gets at equity and fairness throughout the population. And it's crucial that in any circumstance where people and systems are working together, there has to be transparency, honesty, and agreement as to how these things are going to be managed. One of the lessons we've learned is that elective care is not always elective, and patients have suffered by not getting what they needed. So there is a balance in there, but you have to agree upon it, and it has to be fair to everybody, especially to the patients, of course, but to the health systems too, because that good faith is tremendously important in providing and delivering the equal and equitable and fair care to everybody. Yeah. Thanks, Doug, for noting that.
Yeah, that's spot on. And I want to just point out to all of the attendees in the Q&A, I think it's in the Q&A, maybe in the chat, we're posting a number of different articles and examples of load balancing approaches in Colorado, Arizona, I see, maybe elsewhere. So please do avail yourselves of those resources as well. I'd like to turn some of the focus now on our discussion to nursing and the nursing shortage. Tanner, thanks very much for your great insights and comments. And there were a number of really, I thought, very thought-provoking questions about this issue, starting with this notion of a nursing reserve. Do we have the opportunity to develop a nursing reserve? What might that look like? How might we put that together? Thoughts on that?
Sure, Dan, thank you so much. And there have been a number of conversations looking at what type of additional nursing assets could we either develop or establish, and would that be a federal asset? I was on the phone yesterday with the new chief nursing officer at ASPR, brainstorming what types of models we might think about pulling together going forward from the federal perspective. I would also say that at the state level, state departments of health are not working in conjunction with state boards of nursing to think about, is there a critical need to develop some nurse rapid response teams? So you would have perhaps some nurses who were knowledgeable of public health emergency response and health systems management, who also had high levels of emergency and critical care experience, who perhaps could be deployed to some of the more rural or less well-resourced hospitals to help beef up their nursing staff and get them through some of the crises. Those conversations are happening, but the development of those assets, I think, are not going to happen in the near term. And of course, the real concern is those 10 states where we are seeing that they are absolutely in the midst of a nursing crisis, and we're running out of options. We've looked at those short-term strategies, such as mobilizing nurses who are currently in full-time administrative roles or nurse educator roles or quality control roles, and trying to have them re-enter the clinical arena, but recognizing that some of these nurses may not have done clinical nursing care in many years, and so there's a huge gap in terms of being able to upskill them quickly. Also, to Dr. Dichter's presentation, in terms of looking at more elastic, more innovative models for staffing critical care areas in emergency departments. I fall back, and I don't want to date myself, but back to the days where team nursing and float pools. I mean, when I first got out of nursing school and was working at Columbia Presbyterian in New York City, I oriented through the emergency department, through the critical care unit, and through the PACU, so that I could be mobilized as needed across a number of services. And so I think going forward, hospitals and healthcare administrators would be very well served to really completely reevaluate, again, the way they recruit, hire, and assign and develop their nursing workforce. I'm going to posit that for way too many years, hospital administrators have built into their business plan that nurses will do overtime, will come in on their days off, will do those extra shifts, to the point that now we've seen that was an over-reliance on staffing resources that only contributed to burnout and a sense of betrayal amongst nurses. I think that going forward, again, nurses are extraordinarily committed to their patients, to their families, to their communities. But again, the perversities of the way we finance nurses, in hospital-based nurses in particular in the US, has shown that they will vote with their feet and join the traveling nurse organizations in order to do what all of us do, optimize our incomes to protect our families. And so again, I think we really need to look at that. And then finally, one comment is nursing as a profession has been extraordinarily reluctant to embrace technology. And I see such opportunities here for telenursing to have put iPads in patients' rooms and be able to provide much more emotional and behavioral support to patients who were isolated, who couldn't have family members visit, to, again, remote telenursing, where those of us who have critical care and emergency experience could have provided support, supervision, and some remote access to real-time decision support. Those are things I think that we can look at going forward.
Yeah, thanks, Tenor. And I'll just foot stomp on the last point about technology and health security. You know, this is an area that I've been focusing on the last number of years. You know, the fact that we have within our reach, you know, capabilities with regards to sensors and, you know, wearables and other capabilities that allow us really to offset a large portion of care that does not require hospital, you know, intensive hospital oversight, may require some interventions, but adding a telehealth or other sort of, you know, teleconnectivity to patients in conjunction with the ability to monitor and watch their vital signs and other key parameters, we can actually change really the way that we deliver healthcare. And I think, again, in the context, sort of a sub-theme to this discussion, as we come out of this pandemic, God willing, we'll have the opportunity to make improvements and improvements that both ensure access to care, but also allow us to be smarter about how we deliver care, where we deliver care, when we deliver care, and so on. Critically important points. Anu, go ahead.
I'd just like to add a couple of thoughts. One, I think that the key thing here is we all need to recognize, I think we all have drank the Kool-Aid, but we need to make everyone else recognize that staffing, nurses, respiratory therapists, pharmacists, and physicians, and everybody else in healthcare is not an infinitely stretchable resource. It is a finite resource, no different than beds, ventilators, and things like that. And I think that's where, a nurse can take care of 4 ICU patients just as easily as they can take care of 2 patients is really flawed. And I think that's actually how a lot of state leadership either has codified it or chooses to believe it. I also think that awareness and accuracy and thinking about our staffing shortages is really critical. And if you look at most state COVID metrics, taking the acute moment, they're looking at the number of beds in a hospital. And that is a static denominator that doesn't fluctuate, which we know is false, right? We can only put patients into beds that are staffed. And understanding how we accurately measure our capacity, not as a function of physical space, but of human beings that actually provide the care, nurses, respiratory therapists, pharmacists, and physicians, I think is a critical change. And then I think that there's another added area of technology that we can do to help extend some of our nursing resources right now during this pandemic. So one of the things that I saw early on was that nurses, especially in the ICU, are wasting so much time putting on PPE to enter a room to just subtly change a drip and then having to take all that off. There was also, especially early on when we didn't know what the optimal PPE was, each time they entered the room was concerns that they were bringing this virus home to their family. And so what we really quickly implemented was really long tubing taped to the door, and all of our nursing poles for our COVID patients are outside. And I don't know if that's been implemented in most hospitals, but that's actually saved a ton of time and a ton of distress amongst our nursing colleagues. And similar things could potentially be achieved on the respiratory therapy issue that has long-term patient safety benefits. I noticed early on that we were not weaning our COVID patients as aggressively on the ventilator because of how long it would take to get into the room to subtly change the FiO2 or whatever other vent setting there was. And so it would take an entire day, partially because of a high number of patients, and we didn't change our respiratory therapy staffing because that's not a metric for capacity. And so I've seen technologies where literally you can either remotely dial in to the ventilator to adjust settings so you don't have to put on the PPE, or a detachable screen that can actually be positioned outside. I've tried to automate my house. I can be 1,000 miles away and still dial into my security system or my thermostat. And I feel like we should be pushing some of these technologies to help expand, potentially going as far as I make a phone call and a respiratory therapist who is not even physically on the unit, but sitting in some sort of centralized command can institute a change, and there are ways to monitor. I don't fully advocate for telehealth because I do think that there are some limitations. I've done EICU telehealth type care. And I think that there's really some real communication limitations, but I do think that we can push our technology to not address the staffing shortages, but to fundamentally change the types of work that is necessary to take care of our patients in a meaningful way that allow people to do more actual patient care.
Yeah, no, that's great. Although I'm probably the counter to you. You have black hair, I have white hair. I've got 3 remote controls. I still don't know how to turn on my TV. So yes, you know, we know where the limitations are, but absolutely, without question, we have a whole host of capabilities on the tech side that can serve as force multipliers to delivering care. And we ought to be using these opportunities now to start implementing them and then addressing the regulatory considerations that will certainly follow thereafter and allow our regulators in Washington to understand that this is what we need to be able to deliver efficient, effective, and safe care, because that's really what we're trying to achieve. So I want to bring up one of our original Crisis Standard of Care Committee partners, Dr. Asha Devereaux, to address the issue that was brought up in the chat, in the Q&A by Josh Cohen around the oscillations that occur between contingency and crisis care and how to navigate sort of, you know, one day you're in crisis, one day you're in contingency. And I think as a group, Asha, who's been working with Jeff on the task force and others, have highlighted just how important contingency care is. And I think Jeff posted early in the chat the recent publication that addresses contingency care strategy. So Asha, thoughts on how to emphasize staying away from crisis and staying in contingency, if not conventional care?
Thanks, Dan, and everyone for this excellent discussion. The fact about we've all been in chronic contingency, and that's basically why we're having this discussion right now, and the entire healthcare workforce is exhausted. And when you've been kind of jerry-rigging, modifying your practices and delivering a standard of care, and then you suddenly don't have enough and you're in crisis, is almost too late. And that's what we have to just remind each other, that you don't want to slip into that gray to red zone. And in the papers just published in the last couple of weeks, we want to be able to alert each other in hospital systems that when you see yourself heading that way, that's when you call for help. You don't want to try to say, okay, I'm in crisis now, because then it's a little too late. And I think if that's one point to remember, is that if you're in the gray zone, that's when you call for help. And try to regionalize, try to get the governors to talk to other governors, and really make some hard decisions in terms of load balancing. And I did share what California has done. Early on in the pandemic, we were transferring hundreds of people across the state. And I think that's something, lessons learned, and to share with others. There are mandates that public health officers can implement in order to load balance and to make health systems share. And I think those are some things to help remain in contingency standards. So I thank you, Dan, and everyone for these excellent conversations. And I think our one homework item is a national standardization conversation on criteria and how to have an all hazards triage system and oversight. And I think that's something we all need to think about.
Thanks, Asha. Yeah, you know, thanks for reminding me about the California dictum. And I'm glad if you put it in the chat. I didn't see it, but I think that's very important, because that does get back to a couple of the comments and questions earlier about, you know, maybe it's time to force regions to actually adhere to a load balancing plan. And that is exactly what the state of California decided was necessary and implemented. And I think that is a big lesson learned, a big opportunity for other communities to learn from, and hopefully have conversations that may lead to something equivalent or similar Again, the last thing we want is to have, hospitals on one side of town overrun and incapable of delivering care while the other side of town is doing hips and knees and lower backs and whatever else. We're at a point, again, in a health crisis, in a public health crisis, in a public health emergency, we have to invoke certain rules that allow for the improvement and capability that are needed for all. So I'm mindful of the time. We are reaching the top of the hour. We've had a robust set of discussions, some excellent presentations, all excellent presentations. We've had wonderful questions from the participant audience, and we thank you very much for sticking with us and for prompting us and asking these questions. And what I hope you will gather from all of this is that none of us have all the answers. Collectively, all of us have a lot of really good answers. We have to continue to string them together. We have to continue to be open in our dialogue with each other, and we have to continue to share what we know and what we've learned to try to improve healthcare for others. Crisis standards of care, as quoting from our paper, from last month, crisis standards of care occur, and the degree of resource shortages require decisions that place a patient or provider at risk of a poor outcome. Those are poor outcomes that we don't want to have to, contend with. I mean, none of us went into the healthcare delivery business to deliver poor outcomes. We always want the best for our patients. And now we're being stressed. We're being challenged in a way that we haven't been before. And we have to rise to the occasion. And I hope that at the very least, this systems framework that we call crisis standards of care, as imperfect as it is, with all the hiccups and bumps and bruises that it has accumulated along the way, can be useful to you in your communities to help you work through the very difficult decisions that I know you're contending with, right now. But again, this conversation is not over. This is just the beginning of our conversation. So I'd like to remind you that National Academies will be hosting a series of additional webinars that will be focused on crisis standards of care. It's essentially a series of workshop discussions. If we were not in COVID, we'd all be convening in Washington, or maybe in Irvine, or maybe in Chicago, or maybe all three, or other points in between to meet face-to-face and to work on these issues together. Instead, we'll allow Zoom to be our platform. And the first of those webinars, again, as a reminder, will be held on the afternoon of September 27th. That's noon Eastern. The link, I believe, is in the chat, I believe now. And there will be links to the subsequent meetings that are set for October 11th, October 25th, November 8th, and November 22nd. All told, intended to really take a deep dive and looking at crisis standards of care. I should also make note of our planning committee chair, Dr. Eric Toner, who has listened in on this call, but who was driving, and I did not want him driving and talking at the same time. So we thank Eric for being a part of this, and Eric's leadership, along with all the planning committee, in helping to put together those upcoming workshops, I think will yield a lot of additional excellent insights and information to share with all of you. So with that, again, I thank everyone for being a part of this discussion today. We are going to have recordings of this session available to you. They will be made available on the National Academy's website. We also will have the slides available to you pending approval of our panelists. And with that, I wish you a very happy and safe upcoming weekend, and wishing everyone all the best in the days ahead. Looking forward to seeing you again soon.